Welcome to this episode of Substantial Matters, Life and Science of Parkinson's. I'm your host, Dan Keller. At the Parkinson's Foundation, we want all people with Parkinson's and their families to get the care and support they need. Better care starts with better research and leads to better lives. In this podcast series, we highlight the fruits of that research, the treatments and techniques that can help you live a better life now, as well as research that can bring a better tomorrow. Parkinson's disease presents many challenges, both for the people with PD and for their care partners. Problems can be physical or emotional, and intimacy and sexuality have aspects of both. In this episode, we focus on problems that care partners experience concerning sexuality and for which they call the Parkinson's Foundation Helpline. Social worker Anna Moreno, a senior information specialist at the Foundation, highlights some of the more common questions that she receives, and her job entails helping callers find the right resources. Gila Bronner, a certified sex therapist and supervisor of the sex therapy services at the Tel-Aviv Sourasky Medical Center in Israel, responds to these questions with insight into the problems and some approaches to solving them.
Anna, you are a Parkinson's Foundation helpline specialist. What kind of questions do you get concerning sexuality, keeping in mind that you yourself are not a therapist?
We get a lot of questions. So one thing we do is we refer people and help them find therapists through the American Association of Sexuality Educators, Counselors, and Therapists. Some of the questions we get are, as a care partner, how do I explain to my husband that I'm just too tired to have sex because I'm always caregiving? And people always ask, too, I'm an older woman, so I just don't really have a libido anymore.
Usually, the idea of lower sexual desire, or what I call a sexual desire discrepancy or gap, one of the reasons is the burden. I mean, the partner who lives with Parkinson, he doesn't have Parkinson, but lives with it, is very tired. And the woman who is asking it probably is doing a lot of chores, and she's really exhausted. So one of the reasons for the gap in the desire is because of being tired. But the other reason is that the dopaminergic treatment for Parkinson restores desire for the patient and does not restore any desire by the partner. So we have a gap. Now, sometimes I think instead of saying I don't want sex, I don't have desire, maybe we have to teach care partners to say, what do you do need? For example, at the end of the day, I need foot massage or shoulder massage. Can you massage my shoulder? And teach the partners that not every touch should lead into sexual erotic activity. And if they do that a few days along the week, just touching, then I'm probably quite sure that the woman in this question will have a desire to be more close to her partner, to her husband.
And is there an aspect there of just being older and having diminished sex drive?
Yeah, people lose the sexual desire to have erotic activity. But one of the reasons that they lose it is because they stop touching just for the touch. Because most of us as persons at any age, we need to be hugged, and we need to be touched, and we need to feel excited, and to feel loved, and not only to have the desire to have intercourse or get aroused or get orgasm. The moment we lose the intimate touching part, it reduces also by many times the desire to have sex. Because when you look at studies and you inquire older people, I mean people in their 60s, 70s, 80s, and even 90s, you ask them, they say, yes, we adapt our intimate activity to what we like and what we can, and not always need to have the erotic sexual activity.
Anna, what else do you hear from people calling into the helpline?
One interesting question that we get a lot is that people say, my husband, and on the helpline, we've only had opposite sex questions. We haven't heard from same-sex people, but one of the questions is, my husband experiences delayed orgasm because of the medication, but I cannot just keep going. It gets uncomfortable for me. What do I do?
In Parkinson, some of the medications, especially those who are for treating anxiety or depression, may disturb the ability to reach orgasm. But not only the medications. We have to remember that Parkinson is a motor symptoms disease. It means that sometimes people choose positions where they cannot hold and where they do not feel steady enough, and they can't do constant movements with concentration that are needed for orgasm. And some people are choosing the timing of sexual activity when they are too tired, not concentrated. Sometimes it's too late during the night. So what usually we do is, when I have a couple like this, I will usually ask the woman, how long is it okay for you to have a visit in your vagina? I mean, of your husband's penis. And many women would say, look, 2 minutes, 3 minutes, 4 minutes, okay. Let's think of, once we had a special clock, we called it sand clock for boiling eggs. So I'm saying, yeah, we should think about something like this. And when it is fine with you, okay with you, you can't have it anymore, ask him to go out whether he reached orgasm or not. Because the deterioration of your interest in sex because he's staying there too long, it's much worse than stopping the sexual activity. Now, we should think, why doesn't it come? If it is medication, we can ask maybe the psychiatrist to prescribe them or another physician, and we can ask if we can change it, or maybe we can lower the dose, or maybe we can do something like once a week or once in 2 weeks. We call it weekend vacation. Weekend vacation means that we stop for example, the antidepressant for 48 hours. And if we get an okay on the medical side, then sometimes during this break, at the end of this break, if the man will have sexual activity, he can come. But on the other hand, we have older people, meaning from the age 60 and on, who have problems in coming, in reaching orgasm, even if they have no Parkinson and no medication. This is one of the changes which happen when we grow older. So it means that you can visit the vagina as long as it's okay for both of you, then go out and think of another way of getting aroused or getting excited more effectively, for example, manual stimulation, and get orgasm in a different way. And this is what usually older people do when they have problems with their orgasm. So it means that we need a little more education for the people and giving them options and seeing what is the best solution in each case.
Anna, what's another question that you've been getting commonly on the helpline?
Sure. A lot of men have called us feeling very upset about, they want to know why their wife doesn't want to have sex with them as often as before. And that's many reasons, I'm sure.
When we think of this question, there are many options. One of the options is that unfortunately, in the whole world, not only in the world of the Parkinson and not only in this age, but in the whole world, many couples are having sex which is more satisfying for men without listening to the needs of women. So sometimes what we do is we need to teach them. And it comes a moment when the woman says enough is enough. Many years, it's like if we are thinking of eating something, for many years I was eating your sandwich. I don't like the sandwich. I need the sandwich to be differently made. And now I don't want any more this sandwich. Okay? So sometimes this is the reason. For many times in Parkinson, it's really the burden and the need to serve all the time. So you don't want to serve sexually. And the best thing is when I can teach these men really to pleasure the woman without touching the erotic area. And the nice thing and the female body is the women can enjoy very much, have really a lot of pleasure and feel loved and feel also love to the partner when they are touched in other areas of the body. For example, pleasuring the back or the neck or the head. It depends, everyone is a little different. Just hugging them, just lying close together, with clothes, without clothes, but not without trying to reach to the erotic part. But men, basically many men, were educated that if you touch your woman and you touch her, you have to do something. You have a job, and if you don't do your job, you are not a man. So we have this problem. Then we have a lot of specific problems in Parkinson because men changed. The men with Parkinson changed. Sometimes cognitively this man changed. His behavior changed. Sometimes communication changed because of problems speaking. Sometimes the appearance changed, the way the partner walks or the way the skin looks. So sometimes it's really issues of attractiveness. So there are many reasons why women do not want to have sex. I can share with you that in a workshop that I've done with men with Parkinson, we had a group of 40 men in Parkinson, and they were talking quite open, quite free. And many of them said, I feel that my woman is disgusted by me, or I feel that she's really reluctant to be close to me. And it's very sad, and we can think together what we can do. It's not easy. We have to ask the men and the women, how can you leave the sex away, the erotic sex, and try to be friends first. Try to listen each one needs. And then we can habilitate the erotic part of their life.
Anna, why don't you give me one more of the questions that you get commonly asked?
Sure. So one of them is, my husband has a sex addiction. How do we manage that? But also, how do I manage my anger about that?
If you talk about sexual addiction in Parkinson, this is a real problem. It's a big one. And it is part of the impulse control disorders. We know that because of the dopaminergic treatment, some of the men, depends on the study, about something between 10 to 15% of the people with Parkinson, mainly men, will have some kind of addiction. It can be gambling, it can be shopping, it can be eating, it can be walking about, wandering, but it can be also sexual. But not every sexual behavior which looks like sexual addiction is really sex addiction. I want to give you an example from my patients. For example, I had a patient, he was 50 years old, young, he had Parkinson, and every day he tried to have sex with his wife. But he had problems with his erection, so he did not succeed. So he tried on Sunday and he didn't succeed. He tried on Monday, he didn't succeed. He tried on Tuesday, he didn't succeed. And like that, he was trying all the time. He went to the doctor, he asked for some kind of medication. He got one of the erection pills, but the doctor did not explain to him that in Parkinson, because of absorption problems and slowness of the gastric system, it takes sometimes double time for the absorption of the pill and not 1 hour, as they tell every patient, the physicians. So my patients with Parkinson had to wait between 2 to 3 hours until the pill was in its blood in order to be effective. So they try the pill and they also do not succeed. So they try another pill and another pill. And after a month, the woman will come to the doctor and says, my husband has sex addiction. And I can tell you truly, he doesn't have sex addiction. He has a sexual problem or sexual dysfunction which is not correctly treated. Okay? But we do have a problem of impulse control disorders, which we call hypersexuality or compulsive sexual behavior, meaning that there is a behavior that did not exist before, and it is really bad. Actually, we have to take and recruit all the multidisciplinary team, which we can. In my department, this is what I do. I talk to the nurse, I talk to the social worker, to the physiotherapist, to the occupational therapist, speech therapist, to the neurologist, to the psychiatrist, to everyone. Sometimes we even think together what we can do, because in these cases we have to adjust medication. Sometimes the neurologist will choose to use one of the advanced treatment devices like the DBS, the brain stimulation surgery, or sometimes the intestinal gel. And we have to educate. This is what I usually do. Me or the social worker or the psychologist, we educate the couple. Because a man who has sex addiction is at risk. His sexual health is at risk. He is at risk of getting sexually transmitted diseases, of getting AIDS, of being abused or abusing others. So we have to really treat a real sex addiction from all the aspects that we can. But we have to differentiate it from a real sexual dysfunction that has to be treated in the usual intervention for sexual problems, which is really different. Educating patients about that releases their stress, and the anxiety is reduced. And sometimes reducing the anxiety is alleviating the problem and making it quieter. We did not solve it, but the feeling, the psychological atmosphere is a little different.
Gila, let me get back to something Anna said earlier, that most of the calls she gets on the helpline, or all of them, are from heterosexual couples. Do you ever see same-sex couples with Parkinson's disease, either male-male or female-female, who come in with problems relating to sex? And are the answers essentially similar to what you've proposed for heterosexual couples?
Unfortunately, very few LGBTQ person with Parkinson come for sexual counseling. They feel it's a minority in a minority in a minority. But interestingly, in the last year, I was one of the teaching personnel in a special project which was done in Boston with people from the gay, lesbian, and queer and transgender community with Parkinson. And I had a workshop with this group. And then, actually, at the World Congress of Parkinson, which will be in Barcelona 2023, I am presenting a pilot which we plan to do on interviewing people with Parkinson who are part of this community. Now, if you ask, most of the sexual advice will be very similar to heterosexual community with Parkinson, but there are a few specific points which are very specific to men who are homosexuals, to women who are lesbian, and we have to refer to them. I'll just give you an example. For example, in the community of the homosexual men, I mean the normal community, not something special, the attraction, the physical attraction is very important, and it changes in Parkinson. Erections are very important. You are counted by your erections. So this is really a problem because the frequency of erectile dysfunction among people with Parkinson reaches much higher than 50%, sometimes 60 and 70, 80% in many studies all over the world. So it's a problem. Then we have a problem with the gastric system sometimes. For example, constipation. Some of the people who are homosexual, some of them, not all of them, but some of them have anal sex. and they might have specific problems because of the contraction of the muscles in the pelvic floor area. So there are specific issues, but generally most of them suffer from everything. And in heterosexual couples, in many cases, women will not leave their husband because he has Parkinson. I mean, divorce or separate. But homosexuals are usually not married. And many lesbians are not married, and also other people from the LGBTQ community. So it's very easy to break relationship. So sometimes they suffer much more from loneliness, and we have to find other solutions for them.
Just to wrap up, overall, when should a couple seek out a psychologist, a marriage counselor, or a sex therapist? Are there any triggering events, or is it just a long, ongoing process by which they would finally come to a professional?
I would love that every couple or every person who is diagnosed with Parkinson at a very early age will come for just one talk to a sex therapist, just to learn how do I arrange and get ready for the changes that are coming. It's like the many neurologists today, when they diagnose a person, they say, look, at the moment, the only intervention I would like to give you is start to make more sport, invest in more physical activity. Because what I need is that people will learn how to communicate better. Many people are not communicate freely when it has to do with intimate issues. So I need better communication, because later the problems with communication will be piled by so many other problems that it is really difficult. And then thinking about roles, how to change the roles, this can be done also by a couple therapist or by a psychologist. So some of the things can be done by psychologists and couple therapists. There are specific issues that sex therapists do because other professions do not talk very openly and freely about sexual and erotic issues. So I think that people should use it. And it's not a long treatment, just really a counseling session. That's all.
Anna, is there information on the Parkinson's Foundation website about how to find a sex therapist?
Unfortunately, no, but if they call the helpline at 1-800-473-4636, we can help them find someone.
Very good. Excellent information. I thank both of you. And this has been a discussion that I think people might shy away from, but it's very necessary. So thank you very much.
Anna, thank you, Anna, for the questions.
Thank you, Gila and Dan.
You can find several helpful blog posts on our website at parkinson.org. Just search on the word intimacy. For ones specifically by Gila, search on her last name, Bronner, on parkinson.org. That's Bronner. You can also listen to a previous podcast with Gila called Navigating Sexuality and Intimacy with PD. For a fact sheet on intimacy and PD, go to our library at parkinson.org/library and search on the word intimacy, where you will also see a link to Gila's earlier podcast. Gila says that in the United States there are great professional organizations that can offer help in finding qualified sex therapists. One, as Anna mentioned at the beginning of our discussion, is the American Association of Sexuality Educators, Counselors, and Therapists, or AASECT for short. It lists sex therapists and sex educators by U.S. state, as well as in other countries. Just go to aasect.org. SIECUS, originally the Sex Information and Education Council of the United States, deals more with sex education and social change. It can be found at siecus.org. News and updates about future events and resources are available by joining our email list at the bottom of our website's homepage. If you want to leave feedback on this podcast or any other subject, you can do it at parkinson.org/feedback. If you enjoyed this podcast, be sure to subscribe and rate and review the series on Apple Podcasts or wherever you get your podcasts. At the Parkinson's Foundation, our mission is to help every person diagnosed with Parkinson's live the best possible life today. To that end, we'll be bringing you a new episode in this podcast series every other week. Till next time, for more information and resources, visit parkinson.org or call our toll-free helpline at 1-800-4PD-INFO. That's 1-800-473-4636. Thank you for listening.